Australia's private hospitals are battling outdated coding rules, workforce shortages, and inefficiencies in revenue cycle management. But surely AI and automation are going to swoop in and save the day, right? Welcome to this special live recording of a Talking HealthTech podcast episode where I speak to 3 experts from Australia's leading private hospitals. And in this episode, we talk about the real impact of coding complexity on hospital cash flow, why AI and automation are failing to deliver in Australia's system, the policy and funding roadblocks that keep hospitals stuck in the past, and actionable steps to improve financial sustainability. We've got a load of live attendees here in the chat for this one, and it's a great representation of the digital health ecosystem. We've got strong representation from the vendor community, private hospitals, consulting and advisory, research and education, as well as government and regulatory bodies. 32% of attendees are from the digital transformation and IT world, 16% are deeply embedded in health information management, 8% are from financial and business operations, and 6% are clinical coders. Got the decision makers here in the room too. 37% are senior managers that are in the thick of it, 19% are C-suite and executives, and 14% are founders or partners or owners in their business. There's strong representation from the clinical frontline too, with 14% in there as well. So we want to make sure this session hits all the topics that you want to hear about. And in the survey, most people wanted to learn about AI, automation, and interoperability. But also there was a fair bit of interest from attendees on optimizing revenue cycle, as well as the impact on clinical coding on hospital revenue, as well as policy, regulation, and of course, workforce shortages. We asked you before the session, what are the biggest challenges that you face in revenue cycle management? And boy, there were a lot of them. The key themes that came through loud and clear were access to documents and digital records, workforce shortages and inefficiencies, adoption of new technologies, financial pain points, and manual processes and forms. You also had a lot of questions on your mind going into this session. Everything from digital transformation and efficiency. So how can hospitals fully transition from digital systems, overcoming staff resistance, and improve financial management without restricting doctor workflows? Revenue cycle management and workforce challenges. What are the biggest inefficiencies in revenue cycle management? And maybe how can AI, clinical automation, and workforce strategies help optimize revenue and reduce reliance on agency fees? You also wanted to know about the return on investment on some of these things. How can private hospitals ensure high quality data to support better revenue cycle management? And where should organizations invest for the highest ROI? So look, there's a lot to unpack there, and we'll try to touch on all of those throughout this session today. If you're here live in the chat, make sure you drop a comment or a question as we go so you can help shape the conversation. Let's get stuck into it. Welcome to the Talking HealthTech podcast. My name is Peter Birch. We're here live. If you're here in the chat, drop a message. Let us know that you are here as well. G'day, Lyndon. We've got Elizabeth. We've got Nicole. Everyone's kind of streaming in, ready to help us shape this conversation. G'day, Debbie. They're in the chat too. We got Cara, and we'll let those continue to load on in. So looking forward to really diving into probably the funkiest conversation about revenue cycle management that you're going to have in your lifetime, because we've got a funky panel live joining us here today. What I'm going to do, I'm going to allow for each of the participants to give a quick intro about themselves and who they are. But what I'm excited about is we've got great representation from across the private hospital ecosystem in Australia, and these are people in the thick of it. So I'm hoping for some real world actionable stuff about, you know, the role of data in healthcare and the impact on revenue cycle management. Oh, I looked down for a second and then the comments continued to stream in. G'day, Brad, Francisco, I'm sorry, mate. Good to see you again. Anita, Sarah, Karen, Kath, Rick, Sarah, Michael. Hoping to see lots of comments and questions as we go. But let's go around the room. Charles, I might start with you to introduce yourself. Tell us who you are and what you do.
Thanks, Pete. Charles Lee, Group GM, Revenue Cycle Management at Healthscope. I've never been introduced as funky before, so thank you for that. Look, at Healthscope, we've got 38 hospitals across all states and territories in Australia, and our RCM function is very traditional. So, coverage over front office admin, CDS, CDI, coding, billing, collections, and health fund audits.
Amazing, thank you. And you haven't been described as funky because you've not been on a Talking HealthTech episode before, but first time for everything. Cathy, over to you.
Yeah, thanks, Pete. So Cathy Ryan, I'm Group Director for Health Funds and Patient Services at Cabrini Health. Not quite as many hospitals that Dean and Charles deal with, but all the same complexities, so fairly rudimentary revenue cycles and a lot of the back house services of healthcare that often get forgotten about in favour of clinical care, which is usually the balance of scales, but it's becoming more and more important that we try and even that up a little bit, because we get further and further behind otherwise.
So true. Looking forward to diving into that. And Dean, got you as well, mate. Over to you.
Howdy ho, everybody. I'm Dean, so I'm the Chief Policy Officer at Ramsay Health Care Australia. 70-odd private hospitals, 100 pharmacies, a 65,000-bed hospital in a home provider, and a whole bunch of other stuff. And look, at Ramsay, I'm responsible for all the funding, public and private, engagement with government at the state and federal levels, and also accountability for revenue cycle. So clinical coding, collections, billings, the whole shebang. So very excited to be here. It's something when I started 7 years ago, I was very passionate about, was increasing attention on revenue cycle and coding and administration teams.
Well, the right person to be in the room, and I'm very grateful for our THT Plus partners, InfoMedix, who've helped us put together this panel today. But the real focus has been on diving into the problem to solve, and that's what we really like to do at Talking HealthTech, is not so much talk about what technology can do, but what healthcare needs. And this topic around revenue cycle management and optimizing and the role that technology plays is one that warrants its own discussion. Charles, I might go to you firstly to kind of help us continue to set the scene. Where do you see the biggest, I guess, inefficiencies or problems to solve in revenue cycle management in healthcare today?
Yeah, thanks, Pete. Look, I think for me, I would say the duplication of administrative burden across the entire system is the biggest inefficiency today, and that gets right back to workforce challenges. So, for example, Healthscope's, as I said, 38 hospitals, and until really recently, each of those sites, and I'm sure many of you guys can relate to this, had their own admin team and function, their own coding team, their own billing team, their own collections team. And we're working really hard at the moment in trying to support those teams and those sites in digitizing some things, either through scanning or automation, or dipping our toes into AI, centralizing and just really supporting those non-patient facing activities. So, for example, we've got a team of collectors who literally a central team of collectors who sit in a room and mainly on the phones every day, calling and chasing health funds around ensuring that Healthscope are getting paid appropriately for work already performed. Now, I assume, Cabrini have got a similar team. I assume Ramsay have got a similar team. And on the other side of the fence, my assumption is that every health fund will need to have a similar team of people that are answering those phone calls. Medibank will have one, we will have one, HC, you get the gist, right? So if you extrapolate that across the entire, every admin and RCM function across private health, there are literally thousands of people who are tasked with those activities every day. And look, in today's environment where pretty much every sector in Australia is facing unprecedented labour shortages, it just seems that this inefficiency is a massive opportunity for all of us, whether we're competitors or we're on the other side of the fence with health funds, to really get together and to address some of those inefficiencies so that we can divert more and more effort and dollars towards that, what actually matters, patient care.
So true. When I think about all of those people that you outlined, because that's at the heart of making everything happen in healthcare, those people, those teams kind of tie it together. But in order for the data to move around, it needs to be in a language, and that's in my rudimentary understanding where clinical coding kind of comes in. I'd love to hear from Dean on, I guess, when it comes to the complexities of coding, the impact that has, given it's not a simple task, the impact it has on revenue management, which is obviously like the lifeblood for any business or hospital.
Yeah, I think it's really interesting in Australia, particularly. A lot of people, particularly consultants and others, are coming to the Australian market with an overseas view on coding and what that is. And essentially, if we look to America and much of Europe, that's key term mapping. The diagnosis exists in a record, you code it. That's not what we see in Australia. We have the coding standards, which provides a much higher kind of burden of proof. Has there been a consumption of resources that is commensurate with a deviation from the standard pathway, essentially, to warrant the coding of that diagnosis? And in doing so, it means that the level of skill of our workforce needs to be so much higher. The quality of the documentation needs to be that much more explicit and precise. And when you put all that together, it makes for a really complex system relying on clinicians, administrative staff, professionally trained coders who have gone off and done certifications and degrees. And ultimately, kind of to what Charles has said, it drives this inefficiency in this, I would potentially describe it as administrative waste in the system, that we all have to then employ teams of people to make sure that for the work that's done, the hospital is remunerated appropriately. Because whether or not you code it, we still have to manage that person's diabetes. We still have that person in the ICU. And so really then it comes down to spending money, time and resources on trying to evidence and document it in a way that will avoid the audits and the fights and all the things that come out of having a system that's really got a lot of red tape and a lot of grey area, which provides opportunity for adversarial waste and fighting.
Yeah, it sometimes feels like, I guess anyone, even if they're outside of the hospital system, would feel like sometimes it feels like I'm spending more of my time justifying what I did as opposed to actually doing the thing that I need to do. And it sounds like, given the importance of it as you've outlined, that it's probably a little bit out of a bit skew-if, to be fair, or maybe, I guess that's what we'll unpack a little bit more. But given the nature of this panel, it's super lucky to have representation from the private hospital scene here for this discussion, and it's a topic that impacts both public and private healthcare. If you're not familiar with the Australian healthcare system, we've got a global audience of Talking HealthTech. Make sure you check out our website. There's a glossary of terms and how the system works you can dive into after. But Cathy, I'd love to hear from you about, I guess, given those challenges, like what's unique in the private hospital space compared to what we know of the public hospital side?
Look, there's really three essential challenges or differences, variances between public and private. Our clinical coding team, our health information managers, need to be very highly skilled because we're like a foreign exchange. We are having to code in version 6, version 8, version 10, version 11, and have to remember all the subtleties around rule changes all of the time and get audited in all those flavors. So apart from the fact that the funding models are so disorganized when it comes to sort of comparability, we see that we have some procedures that will get paid in pesos compared to others that get paid in euros, and all of those different dimensions in the funding models make them really difficult for people to then organize where their resourcing is going to go, because it relies on your market share, it relies on the capability of your coding team, it relies on your ability of your doctors, and our lovely visiting medical officers do have a lot of problems holding their biros from time to time and actually writing in clinical notes with enough specificity that will actually deliver the right outcomes in terms of revenue. I'd say the other sort of challenges for the private sector are really around that workforce, because unlike the public sector, where you have seen the widespread adoption of an electronic medical record, we don't have a junior medical workforce that can sit there punching data into an EMR. We have highly qualified, highly experienced VMOs who don't see that as part of their life ambition, is to be a slave to technology as such. So, and rightly so, they should be out doing what they need to be doing and saving lives. But that's a really big barrier in a private hospital, apart from the outrageous cost of EMRs. It's getting together and looking at what other alternatives do we have. And I guess that's where some of us have happily discovered that, a digital medical record, digital patient chart, and the values of a scanned and hybrid opportunity exists. And then I'd say the last real challenge for private hospitals is, unlike our public hospital colleagues who've experienced the same outrageous cost increases and workforce shortages that private hospitals have had, we don't have a government to bail us out. So we saw in Victoria recently where the Victorian hospitals were over $1 billion in debt come the end of this financial year. Originally, we were told to manage your own budgets and get on with life, but were significantly bailed out and then topped up further, because the reality is we're all under pressure and all trying to do a good job in managing Australia's health population through a single health system, which is made up of public and private.
Yeah, that's a challenge, isn't it? And one that I'd not reflected. I love the foreign exchange analogy for clinical coding, by the way. That's a great way to think about it. You mentioned, VMOs or clinicians didn't become clinicians to be a slave to technology. And Dean, as we're talking about these, super manual challenges of doing repetitive tasks, I can hear them. I can hear the entrepreneurs opening up their API to ChatGPT to create a skin to create because AI can solve this. Dean, I don't know if you've heard about this, but in all seriousness, it does feel like there's a lot of opportunities within healthcare to address. The issues of efficiency and also crunching a lot of information. What's your take on, I guess, AI and automation and the opportunity or the limitations that it has in revenue cycle management today?
Yeah, first I want to acknowledge all the HIMs and the Health Information Services staff that have come before us in the last decades, because sometimes they're viewed as ossified, but literally they are the ones that first pioneered batch coding, which is really, without that, we would need hundreds more coders across Australia. They're the ones that took the data we did have available and started doing statistical analysis, profiling episodes to understand at a doctor level, at a patient level, where was the greatest variance and therefore warranting the greatest attention for the most experienced coders or coding auditors. But I guess what we're looking into now is the next wave of automation and AI. And look, there's probably three distinct parts. There is the documentation, there is the interpretation and abstraction of the information out, and then essentially the coding and the DRG assignment at the end. Those are the three big parts of what we're talking about here. In that first part around documentation, handwriting analysis has been around for a while. I wouldn't say that it's crash hot, although there's been quite a push in America and a number of consulting agencies rolling out those handwriting interpretation products in Australia, which are all right. But essentially, that is a modern solution trying to solve for an old problem. What we're looking at Ramsay is how to kind of make that leap and not have doctors typing on tablets and laptops or having a JMO workforce. And we've piloted in Europe and also in Australia now voice to text. So listening devices that you can use to actually transcribe the record and make it available in real time in a structured, formatted way and typed. That's great. That means we now have more structured information and potentially unstructured information. But also too much information is also the bane of the coder's life. If you go from 4 pages of really salient information to 50 pages of just ramblings, that's going to also impact the quality of your coding. And so we need to then bridge the next gap, which is potentially prompted or filtered questioning in real time with the voice to text to make sure that we're documenting diabetes in the way it can be coded. Moving then to that second part around the abstraction piece, and this is where I have a personal bugbear with foreign overseas solutions coming into Australia and not having Australianized, thinking they can solve the problems. For as long as we continue to have ACS 002 coding standard and ACS 010 coding standards, we'll be really quite limited in the speed with which we can adopt AI. Because it will require the AI to understand the patient's diagnosis and treatment pathway prior to admission, during the admission and discharge, because you need to know, has that patient deviated from their historical treatment pathway for the diagnosis to code it? So that's a lot more information than we currently have access to. And that will perhaps really throttle the ability for that to be a successful solution. That said, I'm very hopeful, and we'll get to that a bit later in the podcast, but I'm very hopeful that we will be able to shift that dial on those regs that are preventing innovation and the adoption of AI, and really having our teams just focus on the stuff that's high value. And then the last piece for me is then how do we actually adjust for the changes in the system to make sure that neither payers nor providers are cheating or gaming the system. So there are appropriate checks and balances in the complexity assigned to the DRGs in the back end.
I think you've nailed it in terms of there's an opportunity there, but understanding the landscape and the way we do things right now is going to be critical, because it's not just a simple solution, but there's hope and there's opportunity. So let's unpack that a little bit more. Charles, I'd love to hear from you about I guess the efficiencies you see to be gained in operations through digitization.
Yeah, thanks, Pete. And just like to fully reiterate both Dean and Cathy's points. I couldn't agree more with the direction those guys were going. I mean, look, as those guys have called out, the funding models within Australia, there are they are complicated. There are some complexities and some limitations. My view and what we're trying to do at Healthscope is acknowledge that and deal with what we can deal with. What the approach we're trying to take at Healthscope is acknowledge that the majority of cases that move through, the private hospital RCM functions can be, relatively simple. For example, day cases that don't require cumbersome volumes of supporting and ancillary documentations can and should be pushed through the system relatively quickly, I think. So I'll give you another example, which is outside of coding, but at Healthscope in the last couple of years, we've been leveraging robotic process automation, RPA or robotics, which many other organizations will be dabbling with as well to help our billing teams. Now, RPA is definitely not new technology and has been around for years and sometimes decades across different sectors, and is nowhere near as exciting or as sexy as AI and Gen AI. But at Healthscope, we've managed to feed over 50% of our claims through the RPA pathways, which has just enabled us to free up and create some operational efficiencies to free up our billers to be looking at those complex cases and really improving the quality of the documentation in those really complex cases to ensure that we get those things right the first time. Another example, Pete, is at another organisation prior to when I was at Healthscope, just digitizing a couple of key forms can really make a difference. Key forms and templates. My observations coming into private health is we talk about EMRs and DMRs, and it all just becomes too big, right, in trying to digitize everything. My experience is, if you were to add up the hours and the effort that would take in printing, scanning, moving files around computers, printing again, signing, rescanning, putting them into the right place, it would blow your mind the amount of hours that we're really taking there. But if you were to take a really targeted approach, pick out the top 2 or 3 key artifacts, forms, and templates that are important for coding in this example, or billing, or reimbursement, or whatever the example may be, I think it could completely transform that process, and with it, an entire organisation.
Look, as an ex-operations manager myself, it warms my heart to hear that the potential for transformational change happens at the heart of how we do things on a day-to-day. That involves getting feedback from the ground and listening to people and really having a reflection on how we do things day to day, because we do them for a reason, and sometimes there'd be those opportunities, as you say, whether it's digitize this form or let's look at this particular step. If that frees up, they're not just 1% changes, they have the opportunity to transform, and we know how impactful it can be to do a complete, rip and replace of a solution. Sometimes it's required, but that's a very different mindset, as you say. It becomes quite big, and you need that full buy-in. So there's stuff we can do until then that's interesting to think about. Hey, I want to throw to you, Cathy, in a second, but just as a bit of a resetting the room, this is a live podcast recording that we're doing. It's going to go out on the Talking HealthTech feed in a few weeks, but if you're here attending live, as with the many others that we have in attendance. When else would you have the opportunity to ask questions or comments to representatives who are in the thick of it at 3 of the leading private hospitals in Australia? So I encourage you to drop your questions or comments in the chat. Thank you very much to InfoMedix, our THT Plus partners that have helped make this conversation possible today and allow us to dive deep into the stuff that matters. So Cathy, I'd love to hear from your side too. So opportunities for technology to help with some of those big challenges. We hear that workforce shortages are right up there in terms of the challenges we face. If we just had more people could do more stuff. But where do you see the opportunity for technology to help or maybe hinder when it comes to coding and revenue management?
Certainly hinder, I would say, and I guess I'll throw to the other side of or what sometimes people refer to as the dark side as such. But and I use this word very carefully to its true meaning, but there is a whole insidious industry in what has evolved out of auditing and the complexity of our health fund contracts and our health funding models. And instead of relieving pressure upon a workforce, it's created even more pressure on a shortage in hospital land as such. So why, and this probably sounds a bit dramatic, but it's the reality, why hospitals were busy looking after people with COVID and managing through a really confronting time in the pandemic. Our private health insurance friends were investing in a lot of technology, and a lot of that was automation of auditing tools to be able to then assess claims in the same way that Charles was referring to the automation of paying of claims. What's that's produced is this multi-million-dollar industry in people and dollars coming away from the bedside in trying to manage this back and forward game. And we know with the Department of Veteran Affairs, they did a study I think nearly almost a decade ago or longer now, where they said, there's really as many mistakes on both sides of the coins, claims being underfunded or overfunded, and it's really a net zero game. But we've invested so many dollars in technology to try and, be quite futile in this space. And a really good example of that is a lot of health funds are using Medicare benefit schedule item numbers to compare to ACHI codes from a coding perspective. These are 2 independent classification systems. They're allocated and assigned for completely different reasons, yet there seems to be this belief that they're always going to align and they're always going to be right or wrong depending on how you audit. This is wasting an extraordinary amount of time because a lot of our really talented coders are our auditors, and instead of doing the job that they are doing to make sure that we've got the right documentation in the right place to get the right outcomes for revenue, they're having to deal with a lot of these spurious claims. And so, it's done nothing to relieve workforce shortages. It's only compounded a problem.
Yeah, interesting. Well, look, I sometimes think about when these compounding problems or big system issues arise, sometimes we need to lean into the rules, I guess. So I've got policy or the what I guess how government can play a role in terms of ensuring we've got the right guardrails to do what we need to do. Dean, I'd love to hear from you about what you think the role of government policy plays in these revenue cycle challenges.
Yeah, I think it's really interesting. I, with my government policy and advocacy hat on, spent a lot of time with the bureaucrats and the politicians talking about this piece. And I think there's a real absence of their understanding of how government has actually contributed to an inefficient and complex system where there is leakage and issues with revenue cycle. And a couple of really simple solutions that come to mind for me are the sharing by default legislation that most recently has gone up. Really good first step. It essentially says if you're a pathology and radiology provider, you must, in a timely fashion, load the results into the My Health record. That is more of what we need so that we can get information in a timely fashion. Problem being, the focus of that is really outpatient results. And so the timeliness won't be enough for us for the provision of care. So we still need that to go further. And one of the things that are really important is things like what the Digital Health Agency is doing around standardized messaging for requests and results. It might surprise you, the numerator denominator for, let's say, iron in your blood could be different by jurisdiction, could be different by the pathology provider that you're using. So to standardize that and to make it then kind of open source, freely available to link in and access the information in real time, that's going to be the real shot in the arm that we need. And again, that's within the scope and purview and control of government to set those standards for messaging and to really incentivize the sharing by default more broadly. The other couple that pop to mind are the coding standards. So those sit with the government agency, IHACPA. They've absorbed the classification rules and obligations. And through the adoption of the old Victorian ACS 002 standard, we moved away from kind of coding diagnoses to this more complex resource consumption deviating from a clinical pathway. If we were to revert back to the old kind of key term mapping coding and then let the complexity scores of the CCLs, the ECCSs do the heavy lifting to assign the complexity at DRG level, that would actually reduce cost, provide a great opportunity for automation, and really address the opportunity for gaming in the system. And the last two are things very focused on private health insurance. One is removing and rationalizing and simplifying documentation red tape. There's things called Type B, Type C certificates. It absorbs the time and energy of our HIS teams, of our clinicians, makes them disgruntled, makes the rest of the documentation become even more of a burden because they hate doing it. And the last thing is similar to the Insurance Contracts Act that applies to general insurers. Let's legislate the definition of a valid claim for private health insurance to really put a lid on all of this fishing expedition and delaying of payment that happens under the purview of audits that aren't really audits. All of those very much in the control of government to fix today, tomorrow, whenever the election's over.
Well, look, particularly I love that there's quite specific ones there that they're covering the coding side and the private hospital space. The secure messaging one always blows my mind. I mean, imagine like in another industry, I wanted to make a phone call to Dean. I could do that as long as, you know, I was on Optus and he was on Optus, and if he was on Telstra, then he'd hear garbled noise or it just wouldn't even connect. So the fact you'd need 5 or 6 phones to be able to just make a simple phone call. The fact that, you know, we've got these restrictions around how healthcare information flies around. So it's great that that's in scope and hopefully with a sense of urgency too. So a conversation for another time for sure, but a great example. Hey, Cathy, I'm thinking about, you know, just generally within any business, but within healthcare too, I guess what gets funded gets done, and sometimes policy and everything can impact funding. You've touched on this a little bit already, but I'd love to understand a little bit more about how you think about the impact of, or I guess how funding models impact hospital financials and decision making.
Yes, indeed. I mean, I think what we've seen over time is funding models become more and more desensitized. And so what I mean by that is it's really hard, as Dean's touched on already and Charles as well, is to really demonstrate complexity. And we know that with age, there's always complexity, but we can't capture it because of the coding rules and the way that they stand. The original intent of clinical coding was for the purposes of population health management, but we've dumbed it down so much. And I don't mean the fact that it's less complex to code. It's more and more complex to code because of the rules that govern it and the discernment that's got to happen. But we have dumbed it down that the allocation of codes that really outline the complexity of a patient just don't get allocated, don't get assigned because of the rules, the burden of the rules. And I think, you know, what really is a key sort of example of that is that we know the care and cost of care is really expensive in the 0 to 4 age group. We know it gets more expensive again between sort of 26 to 36 because of maternity. And then it follows a gradual curve up by decades, 55 to 65, 65 to 70, up to 90, etc. But there's no recognition of that age burden within the current coding models as such. There used to be, but that's all been taken away. And what we've seen is the dismantlement of a lot of these sensitivities such that hospital fundings become more and more complex. to even achieve any kind of positive outcome or margin. I mean, most private hospitals, sadly, if they are at a positive margin, are running on a margin less than a milk bar. And we know what happened to milk bars. And so, the difficulty with this is that we have to have a good hard look at ourselves, and IACPA has to have a good hard look at itself as just how complex and how costly have we got this model such that it's not producing any outcomes. And I think the most unpalatable part about it is that it is so desensitized that our medical elderly patients are being ignored in all of this. Unless you've got an emergency department where you happily have to have your share of medical wards as such, it's very difficult to say that anyone is incentivized to actually manage the elderly complex patient. And that's even in a public hospital as well, because we've got our models and we've got our settings wrong.
Totally. Did you say a margin less than a milk bar? Did I get that right?
Yeah, I did.
Yeah, good. Okay, and so like for our Gen Z and young millennials tuning in, a milk bar was the corner store that you could buy
That's it.
things which Woolworths and let's not get into the supermarket.
The saying used to be you wouldn't open a milk bar for that margin, and the margin of a milk bar used to be around 5%. So
there you go.
Tragically, that's a maybe an old-fashioned saying, but it's true.
No, let's bring it back. Bring it back, and there'll be modern milk bars too with higher margins. But Charles, I'd love to get your take on it too. Because we're talking about policy and industry landscape and how it impacts. And I guess there's a lot for the industry to focus on. Where do you think industry should be focusing on to drive more meaningful change?
Yeah, thanks, Pete. And look, I completely agree with a lot of the examples that both Dean and Cathy brought up, and I won't traverse the same tracks because I just completely agree with them. But I think aside from, there is 100% an advocacy channel that the industry and all of the key providers within the industry, whether it be funding or service provision, should take. I think that, that can take time, and some of those can, may not actually get off the ground and can take a couple of cycles through elections and politics and the like. I think from an industry perspective, the industry itself, it can be somewhat adversarial at times, as someone had called out earlier. But I'm of the view that we've all got the same vested interest in making the industry and the sector as most efficient as possible for everybody. And at the end of the day, if you ask any of us, there are limited dollars that are flowing into this sector. And I think we'd all want to make sure that the highest proportion or the highest margin of those dollars as possible goes towards patient care. In terms of exactly where, I don't think it really matters. But at the end of the day, I think, as both Dean and Cathy have sort of pointed out, a lot of it comes down to data and how we manage that data, how we store that data. And if both service providers and funders can both get comfortable around the safe storage and the safe management of that data in a way that, of course, protects, patient confidentiality, as I'm sure Ramsay, Cabrini, and Healthscope spend a lot of time and effort on, then we can get practical ways and secure ways of sharing information and sharing components of that data that are really important for reimbursement. So I think that would be a great place to start, right? If we could find a smooth way of sharing information that supports any of our funders and also, maintains that confidentiality and security, then I think, we're all winners. Yeah.
Hey, look, singing from the same hymn book there, great alignment in terms of industry collaboration. So some clear focus points for us moving forward. Before we kind of start to think about, what we do with all this information now, I'll remind everyone that's live in the chat, start thinking about those comments and questions, because we've got a few minutes at the end, hopefully, depending how long we talk for, to address some of the questions. We've also got a lot of questions that came in prior, but we'll prioritize those that came in live. I can see Kim's already got a question. We'll come to that in a second in relation to bringing new graduate coders up to speed. So drop those in as we start to think about what we do with this now. I'd love to get a take from each of you. Maybe we start with Dean and then we go Cathy and Charles. It's always nice to have, what do I do now? I think about from immediate steps that hospitals can take to optimize revenue cycles. Dean, you can kick us off.
Yeah, I think it's difficult to use Ramsay's experience as a point of comparison or learning, just because we are a group of 70-odd hospitals. So many public and private, and we have access to IHACPA data sets through our costing studies and a whole bunch of other stuff. That doesn't translate to the 400 odd hospitals that are private out there that aren't part of a group. And so I think probably my biggest recommendation is to find a friend, if that makes sense. Find a partner organization or many or a group of them or something that you can share observations and learnings with, share anonymized aggregate data to benchmark yourself with, to understand what they're doing. It's very hard being a small island of one when you don't have the likes of a Cabrini or a Healthy or a Healthscope or a Ramsay behind you. And so go find friends, talk, create a network is probably my biggest recommendation.
It's a tried and tested method, isn't it? And, almost like informal masterminds of people kind of comparing notes and therapy sessions maybe, but it depends what you want to call them.
Therapy's important. It's so important.
Absolutely.
You think you're going a bit crazy sometimes dealing with the health funds.
Yeah. Well, a problem shared's a problem halved. Is that the saying? So, there's plenty sharing similar problems. Cathy, what about you?
Look, I think without the risk of carbon dating myself, I started playing around in the health fund space about 20 years ago. And at that time, contracting was about 25 pages on average. Some of our health fund contracts are over 150 pages. And out of that is just rule and complexity. And some of them are just countering for the likely incidence of a less than 1% event ever happening. They have become so complex and so difficult for people to interpret and understand. There are no, specialist degree courses for claims billing, although there probably should be because it is really, really complex. There is difficulty in terms of clinical coders coming straight out of those courses, even understanding the magnitude. And as I said before, how to code inversions. If you're a public clinical coder, then you're dealing in one currency only, but you've got to know at least 4 in the private sector. So if you think you're a gun coder in the public sector, I think step across and come and see just what it takes to have a really high skill set. And so from that point of view, when you look at how complex things have got, I think the one thing that I would really drive home is wherever possible, simplify. Some of that's technology, as we alluded to before, the ability to be able to scan up documents that automatically attach themselves to the right place in the file. The ability to not create lots of data footprints between funders and providers, because that's just great fodder for any dishonest cyber hacker. And I think we've got to think about those things really seriously. What kind of model do we really want to build that's going to create so many other vulnerabilities or leave so many big gaps, as I talked about before, from the medical patient side of things? So I think simplify wherever possible, and I would keep stating that every single time.
Yep. Love that. What about you, Charles?
Yeah, thanks, Pete. And I love, finding a friend and simplifying. A great couple of examples there from Dean and Cathy. My example would, my suggestion, Pete, would be start small. This, as I think we've covered over the last 43 minutes, I think, this industry is ripe for transformation, and it's just almost everywhere you look, every rock you look under, there's opportunity. But end-to-end transformation can and will take time, and probably years and decades, right? But there's nothing stopping providers, funders, friends, as Dean put it, connecting, collaborating, and making small sort of iterative changes where both parties get a win. That's just clubbing together and doing that for small process changes could be really beneficial. I'll go back to the example I called out earlier, right, where we've got, a bunch of people sitting on the end of a phone calling health funds, chasing payment for particular claims that we've made, 21, 28, 35 days earlier. The data that we collected over a matter of days and weeks, I'm not talking months and years, let us know, Pete, that almost 70% of those phone calls didn't need to occur. Now that's, if you convert that to minutes and hours from Healthscope side, and then you extrapolate that across the other side of the coin for the funders side, and then across the entire sector, that's a lot of hours, right? That could be redeployed into the sector for just one minor change. That could be, it could invest the whole, you could reinvest that into the whole change. That's the way I say it.
Yeah, absolutely. There's some great ones there. I think we could keep the conversation going down that track, but I wanted to come to some of the questions and comments that have come through on the chat here, because I feel like these are really reiterating some of these key points too. Kim's put the question that, given that we've got such a complex system, how do we bring new graduate coders up to speed? Cathy, I think everyone's touched on this a little bit in terms of bringing a new generation up. I'm going to throw to the floor. It's always dangerous throwing to the floor because everyone pauses for a second and then everyone talks at the same time. But we need a little hand emoji like on other platforms. But does any of the panelists want to take this one on or reiterate some previous points they made?
I'll give it a go.
Like a book. Here we go. Yeah.
Hello.
Dean.
One of the things that we've explored is to learn from other parts of our business where we have professional roles. So like nursing, for example, that's really complex. It requires a lot of on the job, on the tools learning. And if we look at what we do with them and how we kind of give them a pathway to learn and grow and graduate.
Hey, Dean, I think I'm losing you a lot. Hopefully that's not me and my internet connection and I've rudely paused you, but I just wasn't able to hear you at all. Cathy and Charles, I'm not sure if you had a similar challenge, or did I just interrupt him over the top of an eloquent chat? I'm not sure. But did you want to go again? Sorry, mate. And we can clean it up in there. Sarah said you can hear fine. So I'll just shut my big mouth and we can clean that up in the. This is what's great about a live record. So it's obviously my internet connection. Apologies.
Well, I'm sure Sarah and many others would have loved a mute function in all the times that I've worked with them.
I'm sorry.
So our learnings were to take that similar framework that we have for the graduate nurses, how we schedule it, peer them up, help them train and learn and reward them also, to have stages. And so look, that's what we're exploring, rolling out that similar framework for clinical coders. It's not going to be perfect, but it's a bit more structure and a bit more treating them like the profession they are. They go and they study, so let's treat them like professionals to hopefully do it, because it is going to be complex and I don't think there is a magic bullet.
Yeah, and I concur, Dina. It's exactly the kind of program that we have in place as well, which is a well scoped out specialty by specialty immersion to really cover off the whole gamut of clinical classifications and procedures, and the extent of the 660. What are we up to? Active DRGs that you'll see obviously in the private sector. So there's a lot of learning to be done. And if it's not done in a structured way with a framework that Dean's also referring to, which I know a number of places have in place, a proper graduate program, then it is, you reap the reward where you invest the time. So it's absolutely worth it.
Yeah, absolutely. And I can see there's comments resonating in the chat there as well too. So I'm glad we can touch on that. I see Anita's put a question here, and I'm just looking to unpack that one a little bit. I think it ties in with a little bit of what Dean said earlier on in terms of, and actually all the participants around, there's a lot of waste in terms of just operational efficiencies. So the question is, what solutions are there for a high resource turnover, unnecessary waste department? How can we implement a data-driven management process to support change in this realm? I guess the way I interpret that is how you might, whose responsibility is it to look at the operational efficiencies in particular departments? Has anyone got any thoughts or comments that come to mind when they look at this question that's from the chat?
I can jump in, Pete, if that's all right. Charles here.
Go for it.
Yeah. Look, I think one of the greatest follies that I've seen, not only within this sector, but in previous experience as well, is people look at transformation, digitization, and automation opportunities as an opportunity to take cost out. And in many cases, it is an opportunity to take cost out. But I think that's a major trap and a major pitfall. I think the way that I like to look at it is operational efficiencies, yes, sure, can be garnered through digitization and transformation and automation. But I think it presents an opportunity to redivert those resources. And I get that there are complexities with doing this, but at the next most complex thing, at the next biggest pain point across an organisation, I think, Dean, Cathy, and myself, we're not just dealing with 1, 2, or 3 major issues and upstream sort of pain points that we need to look at and resolve over the course of time. There will be dozens. And so I think that the biggest opportunity to answer the question is building a roadmap, a well-formed and well-thought-out roadmap that is flexible enough to pivot and redivert and redeploy those operational efficiencies at the next thing, and then the next thing, and the next thing. And if we're still here talking about it in 10 years' time, Pete, I'd be surprised. But there you go.
Yeah, we can chat more about it down at the milk bar. Because they've got to come back. I can see here. So when attendees registered for this one, there was a lot of questions that came through too. I mean, take your pick, but one that particularly stands out for me as we start to round out this conversation would be, if you were to invest in one area, what would it be for the largest return on investment? So if I was to ask the panelists to think about perhaps one area that they think require the most amount of attention in this, again, when the problem we're trying to address is optimizing revenue cycle management. We've got all this opportunity with technology, but also got a lot of the pre-existing systems and the way we do things. And maybe we bundle this in with your final thoughts and reflections as well. So perhaps one thing that you'd hope that other systems would focus on, and any other final thoughts around the session. Charles, I feel like I left you last in each of them because all you were left with was acknowledging what the other speakers said and agreeing with them, and you very graciously added some more context. But I'll let you start off, and then we'll go with Dean and then Cathy to close us out.
No probs. Peter, wasn't taking it personally at all. But look, I mean, similar to some of the themes of my previous comments, I think my view is we are all, if we really look at it, and whether the data is in paper or whether it's structured or unstructured or whether you can read the handwriting or not, we're all going to be data rich, right? It's just that the art here is going to be how do we capture the relevant points of data that are really, really, really relevant. And I'm a big proponent of the 80-20 rule. There'll be 10, 20% of the data points that are actually, driving 80, 90, almost 100% of the value of what's really, really important for reimbursement through the revenue cycle. So my biggest sort of opportunity that I see is really how do we really target what we're looking for, take a really targeted approach to finding a structured way of capturing those data points, and then finding a friend or collaborating amongst ourselves or amongst, the other side of the fence with our funding colleagues around how do we, use that to create value and not erode value, as Cathy was saying.
Love it. Great summary. What about you, Dean?
I want to be pragmatic. So if you're putting up a project to a steerco, to a project management office, for them, the ROI is going to be the biggest increase to the revenue line or the biggest saving in cost. And so in reality, then, the biggest ROI opportunity is anything to automate people and functions out of existence. But I agree with Charles's comment earlier that that's really not and shouldn't be the focus. Even in America, if you go and speak to some of those big revenue cycle companies in the hospital industry, they didn't necessarily save bunches and bunches of money. They just redeployed people to highly specialized work and paid them more for that work. So looking at that, I would say it's probably the top line revenue. And again, it will be something to do with improving the quality and utilization ability of the documentation, whether that be paper or digital. And being able to get that to the right skilled person, whether it's through a scanned record or some other digitized way, to the right skilled person to get the right coding outcome on it. That is probably the lowest hanging fruit with the biggest ROI, to be honest.
When you put it like that, it's makes it gives so much clarity, and I appreciate you taking that pragmatism towards it. So thank you, Dean. Cathy, bring us home. Well, your biggest kind of suggestion and
all right, I'll steer away from milk bars, and I'll be a little bit more controversial, saying what we really need to do is untether funding models from DRG coding as such, because that's the whole insidious industry that's come about by putting the two chained together. I think that if we return clinical coding back to its original intent, being population health management as a really critical part of how we can plan, and had politicians who are going to be courageous about making decisions for health reform, then we would get a lot further if those two weren't coupled. And so if we looked at new types of funding models that took account of age variance, that we made them bulletproof in terms of audit, we would be saving millions of dollars across an industry that could put back into bedside care. And I think we seriously have to get back to that simplification, because we've created the beast. Now we're trying to automate to counter the beast instead of just killing off the beast in the first place and returning it back to a simpler solution.
Yeah. No, look, I think many can resonate with that one, but there's a pathway forward. Look, lastly, for all those that are tuning in live, I really appreciate you making the comments and questions in the chat to help us shape this conversation. If you heard different terminologies and acronyms over on the Talking HealthTech website, we've got a glossary of terms. By the way, we're investing a lot in that this year. We've got dedicated people just building out hopefully understandable definitions, not just AI garbage, but real ones written by clinicians to help you understand the landscape, referenced through to podcast episodes, all available for free to you to check out, talkinghealthtech.com/glossary. And this podcast episode will be released in the coming weeks. So I ask that you share that because the insights came from this and the real world experiences. I mean, super valuable stuff and thought provoking. And I genuinely believe that in the right hands, ears, or eyes, this kind of information can help people think about issues differently. How we change our thoughts, it changes our actions, and overall, we're all, as Charles suggested too, and everyone on the panel, we're all kind of in this for the right reasons. So let's find ways to move that needle forward. Cathy, Charles, Dean, I really appreciate you making the time for this conversation on the podcast. Looking forward to doing it soon.
Thanks very much.
Thank you.
See you later.
Thanks.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.